our goal here was to describe our institutional experiences handling the initial COVID surge back in March, April, and May in Boston at the Dana-Farber Cancer Insitute. And so, seeing the experience first in China and then in Italy before COVID really came to the US, we had a little bit of lead time to sort of game plan how we were going to handle things. And with a goal of continuing to do transplants and CAR T therapies as much as possible within the constraints, because of the pandemic. And so we did a few things in preparation. First of all, the NMDP mandated a few changes sort of everywhere that we implemented as well, one of which was that we preferentially use peripheral blood stem cells for our allo transplants rather than marrow to preserve resources, and also cryopreserving products before they were given to make sure that there were not going to be any issues with transportation of products, with issues around air travel, international travel, that could sort of prevent things from happening on time. So we obviously implemented a lot of these changes, and we also, our donor services team implemented a lot of changes surrounding how we evaluated prospective related donors. We prioritized donors who were local or didn't have to use air travel to come and donate. And we also shifted a lot of the screening processes to over the phone or online rather than in person. So administering health history screening questionnaires for potential related donors, doing verbal COVID-19 symptom screens at various time points prior to physical exam, prior to donation for prospective donors. And by implementing a lot of these changes, we were able to pretty safely carry out transplants and CAR T therapies during this time. We operated at approximately 90% or so of our typical transplant volume. So we fortunately didn't have to delay a significant number of transplants. We did prioritize continuing the transplants that were deemed higher priority, in that the patient's disease was felt to be higher risk, and so the risks of proceeding with a transplant at the time were felt to be worthwhile. We did make some changes in delaying certain transplants. For instance, the multiple myeloma group made sort of a programmatic decision to delay those transplants until, for a few months, until we could sort of see how things were going to go, with only a couple of exceptions where the transplant was really felt to be urgent. And then there were a couple of cases where allogeneic transplants were, the decision was made to delay because the patient's disease was felt to be stable enough to allow that. We were pleased to see that our outcomes at 100 days after transplants were similar to what we've seen in the past. So we didn't really see any detriments in terms of survival or relapse. We also were pleased that none of our patients in the allogeneic or autologous transplants contracted COVID-19 within the first 100 days. And so this was really validating for us in that we felt like our screening processes were sufficient, and the precautions that our staff were taking, as well as our patients, importantly, were really effective in preventing transmission within our very risk patient population. There was one CAR T patient in our cohort that did contract COVID during the first 100 days after he received his cells. He unfortunately had a severe course and died from that disease, which was very unfortunate. But that's sort of the take-home message of our abstract.